Good evening, everyone. My name is Saleh Alshalash. Thanks a lot for the organizing committee for the invite. I really salute you, Dr. Umar. It's a really tough case to follow. It's an amazing result and amazing team. I'm going to be quick because the last session of the pressing failure session. Um, I have no conflict of interest related to this topic. This is a 55-year-old man. He's an English teacher. He's obese. He's hypertensive. He does not really take good care of his blood pressure. He has not been taking good care of his blood pressure. He presented with an NSTEMI to an outside hospital. He presented with classical chest pain that he's been having for about 6 months, but it escalated and it became breast pain. He had mildly positive troponin and presentation. His physical exam, his labs, his echo were all normal. He was seen by a non-invasive cardiologist there, established a very good relationship with that non-invasive cardiologist. He was sent for coronary angiography. The angiographer who did the procedure noticed heavy calcification in the RCA and in the left main, so they took a dry SENI and an AP projection to just demonstrate this. They tried to go right radial at the beginning and they could not because of severe spasm, so they went right femoral. You can see in the ariocaudal that there is marked left system disease. So there is a small circ that has severe disease, and there is moderate distal left main disease as well as moderate to severe proximal related disease. I'm going to keep going in the next projections. The LAD has severe mid disease, and there is moderate or moderate to severe true bifurcation in the diagonal as well. It's a no-brainer. You can see very rich collaterals to the PLV or to the right system. I think this is a very clear surgical case. The patient was told that. He was seen by the surgeon at that institution. The surgeon sat with the patient, offered him CABG. He's non-diabetic, but this is a high syntax score. The patency rate and the outlook with bypass is much, much better here. This was communicated to the patient by the non-invasive cardiologist, by the invasive cardiologist, by the surgeon. He was still not convinced. He came to our institution for a second opinion. I personally sat with the patient. I recommended CABG strongly. I told him your options are CABG, and then CABG. He strongly refused. He was seen by a surgeon at our institution who sat with him, properly explained to him CABG and why CABG is better here. Yet the patient declined CABG. That surgeon was non-Arabic speaking, so I arranged for him to see a third surgeon in an outpatient setting who spoke the same language, yet the patient who's intelligent and really has good knowledge about his healthcare persistently refused CABG. I'm going to show you more pictures of the left system here. I think this shows the rich collaterals again to the right side. You can see here that there is an antegrade channel. It's tapered. The occlusion length is longer than 20 millimeter, and it's a heavily calcified vessel. So the deal that I offered him was that we could attempt to do PCI, and that I'm going to start with the RCA, and if we can open the RCA, then we can maybe offer him complete revascularization. So we'll start with the right. If we're able to fix it, great. Then the left side, although complex, is relatively doable. But if we cannot revascularize that large superdominant right, then it really makes no sense to just do the circ, do the LAD, and leave him be. Again, all these pictures and this angiogram was done at the referring hospital. So after this long discussion, he was brought to the lab. We have 2/6 French femoral guides, an EBU4 and an AL1, and you can see that the occlusion is about 35 millimeter here. The strategy was an antegrade wire escalation and then an antegrade dissection and re-entry. I really did not want to go retrograde here because of the severe significant left system disease. And I honestly thought the heavy calcification in the RCA would actually protect and be helpful in directing the wire into the true lumen or deflecting the wire, particularly that the calcification does not seem to be in the intimal space, but rather is in the media or in the adventitia. We started with a Corsair. We were able to escalate wire from a fielder. Here we have a Pilot 200 through a Corsair, and we got to the distal cap, and it was just time to re-enter. And up until this point, things were going smoothly. I could not re-enter, despite shaping the wire, despite using multiple wires, I could not re-enter. I tried to advance the Corsair. I thought maybe if we advance the Corsair, then I'll have better support to re-enter. But I could not. So I couldn't advance the Corsair, I couldn't re-enter despite shaping the wire. I did not want to advance the wire further than this because we will lose the PDA, and I think giving him an open PLV without a PDA is suboptimal, so I really did not want to do that. So after this, I pulled the wire, tried with a second wire, with a Gaia second, and it really popped in the true lumen, and I was extremely happy. I thought we were done, but then after taking this shot, I realized that we're not in the PDA, but rather we're in a proximal marginal. So I pulled the wire again, and then created a second channel. Again, reattempt with a Gaia second to create a second channel, and hopefully that second channel will allow me to re-enter at the distal cap. I was faced with the same problem. The wire will get to the distal cap, the wire will not re-enter. The Corsair would not advance. I increased the support by using a guide liner. The Corsair would still not cross. And I really did not want to advance the wire further to get more support for the aforementioned reason. My thinking at this point was, why not dilate that segment so that I can deliver the Corsair, so that I can either deliver a Stingray balloon and re-enter, or only by delivering the Corsair and having that support to the wire, then I'll just use a wire-based re-entry. This is the third track, by the way. The third track also failed to re-enter. The wire popped into the PDA here before doing that, but again, it was still in the subintimal space. So I pulled that wire and I did not advance it. So I took a 1.5 balloon. The 1.5 balloon, I advanced it into the distal RCA to where the Corsair was stuck. I inflated the balloon and the balloon ruptured. The balloon ruptured, it created an IMH. The patient was stable. This was really clinically insignificant, but it only created a hematoma, and it really did not allow the Corsair to go further. It only expanded that subintimal space, making the re-entry even more difficult. At this point, I thought maybe I'll take a 2O balloon, expand the lesion, deliver a Stingray, and really re-enter at this point. But again, I've used 95 minutes of fluoro time, and the 2O balloon did not cross. And I thought even if it crosses, an I balloon and then I deliver the Stingray balloon, it probably would not allow me to re-enter because the subintimal space now is so large. Even using a straw technique would probably not help in re-entry. Again, the patient was stable, cabbage is still on the table, so at this point I elected to stop the procedure. So I took 2 pictures, and at least there is a left flow into the PDA and into the PL. So my plan was to stop, present this at a group, for a group of interventional cardiologists, and take their opinion. If we would bring him back for a second attempt, what other tricks or what other ways would we use? And thank you, everyone.